So welcome to the lecture on bipolar disorders, and we'll look at the assigned mood stabilizer drug lithium or carbolith. So definition of bipolar disorder, which is really manic depressive illness, is usually patients experience sudden or drastic shift in their emotional extremes. And if you could remember from the previous recording, the extremes that they go in is episodes of depression followed by episodes of mania. And they can pretty much slide or glide or seesaw between these emotional extremes. So if you remember the key characteristics of depression, so you can experience their lows, which they feel hopeless, they feel signs and symptoms of depression, where they experience hopelessness, they poor self-esteem, versus they can then shift into episodes of mania, what is characterized by symptoms or characteristics of grandiosity, flight of ideas, just that high, that euphoric mood that they experience. So in a nutshell, that's what bipolar disorder is. It's the teeter-tottering between two different types of emotional extremes, which is episodes of depression or then sliding into episodes of mania. So there's different forms of bipolar disorders. Really don't need to memorize these. It's just for sort of knowledge, FYI. There's bipolar 1, bipolar 2, and cyclothymic disorder. Bipolar 1 is where a patient may experience just one episode of manic, followed by mixed episodes. So mixed episodes is where you're having symptoms of mania and depression almost every day in alternating succession for a period of at least 1 week. So if a patient experiences just a single episode of mania, then they can hold a diagnosis of bipolar 1. In your bipolar 2 patients, this is where one experiences one or more episodes of depression, followed by at least one hypomanic episode. And we'll get into hypomania more in a minute, but pretty much hypomania is a less severe form of mania, but your patient is still at risk for psychiatric decline, and therefore hypomania is treated as an emergency. With cyclothymic disorder, and this is where the patient is suffering for at least 2 years from chronic fluctuating mood disturbances, which involve periods of hypomanic symptoms and numerous periods of depressive symptoms. So sort of the same, they're just the number of episodes between depression and mania that the patients tend to fluctuate between, because remember, it's that seesaw or that fluctuation, emotional fluctuation between episodes of depression followed by episodes of mania. So just this general assessment for these patients with bipolar disorder, one of the things that you'll look at is mood. And under mood, you want to look for this euphoric mood, is often associated with mania, is unstable. So when you have that euphoric mood, there's a sense of feeling elated, on top of the world, feeling great, maybe a little bit too great, right? So uncontrolled sort of happiness. People experiencing manic state or mania tend to laugh and joke and talk continuously, but usually whatever topic they're discussing at the time may not be relatable, may not be familiar, so it's almost like they're going off on a tangent, and you cannot connect with that conversation. In terms of their behavior, patients with bipolar disorder can experience hypomania. And again, what is hypomania? I just mentioned, it's a less extreme form of mania, even though it may not significantly impair functioning in the patient at that time. Patients with hypomania feels wonderful, they feel on top of the world, but remember, when they're doing that, they might get themselves involved in activities that will have them expend a lot of energy. And when patients are in this state, they use up a lot of energy. They're not very conscious or aware of taking rest, having proper nutrition. So their increased involvement with social activity and expending that much energy puts them at risk for decline. So these guys do need treatment because hypomania is seen to be easily progressible into a full-blown manic episode or severe depression. And therefore, if someone is recognized to be experiencing a hypomanic episode, they're often brought into the hospital for treatment. What biological theorist notes is that with hypomania, patients tend to have an excess of excitatory neurotransmitters. So those are your norepinephrine, dopamine, etc., and a deficiency of inhibitory neurotransmitter such as GABA. Hence why the drug mood stabilizer, which although the exact mechanism of action of the drug is not clear, the belief is that the drug works on or taps into the biological understanding of why bipolar disorder is occurring in a patient. Continued general assessment. You might also, in addition to mood and behavior, these patients are assessed for their thought processes and speech patterns. And the common speech patterns seen in this patient are considered flight of ideas. This is where the patient is rapidly changing their thought process or their topics in a conversation, presenting with fragmented thoughts and easily distractible. So the flow of the speech is very fast and they're abruptly changed from topic to topic. So it's hard to follow these patients. As they progress into mania or the mania escalates in these patients, their conversation, which was once flight of ideas, might start to convert into clan associations. So what are clan associations? These are just rhyming patterns or rhyming words that absolutely has no connection with each other. So for example, the example we have up there is the train brain rained on me. So these are all rhyming words. They sound great together, but they're not interconnected. They don't contribute or form or give way to a proper conversation. The other big thought process is that of grandiosity or an inflated self-esteem or self-regard, where someone feels that they are capable of doing something just above and beyond, sort of unrealistic in their ability to achieve. So they have these big ideas that really and truly, it's like setting goals that are not realistic or thinking of achieving goals that are certainly not achievable at that time. So a common medication that is used to treat bipolar disorder is a mood stabilizer called lithium or carbolith. It is a naturally occurring salt that is helped or used to control exaggerated thoughts and behaviors that's associated with mania and bipolar disorder. The exact mechanism of action is not known. So pretty much what we're saying is lithium acts like sodium in the body. So therefore, any conditions or any activities that will affect naturally occurring salt in the body will also therefore affect lithium levels in these patients. There are, however, different theorists out there or different theories that speculate or sort of researched on how lithium works. And there are some researchers out there that believe that it works at the neuronal level by reducing excitatory neurotransmitter such as dopamine and norepinephrine, but increases the inhibitory ones such as GABA. And that was even, so these drugs are believed to be brought about based on biological theorists' understanding of why bipolar disorder occurs in a patient. The other thing about lithium is that it's excreted by the kidneys more rapidly than salt. So when put against naturally occurring salt in the body, your body will tend to get rid of lithium. So if your sodium levels are too high, in order to bring you back to homeostasis, your body will excrete the lithium and hold on to your actually not naturally existing sodium and get rid of that lithium in order to bring us back to homeostasis. So the question is, what would happen if a patient on lithium ingests too much or too little salt, and how might this affect lithium levels in the body? So again, what would happen if a patient that is prescribed lithium ingests too much or too little salt, and how would their lithium level be affected by their ingestion of salt? So one thing to remember is the kidney would always get rid of lithium more rapidly than it would sodium in the body. So therefore, let's work this through. So let's say your patient or experiences some condition that cause extreme loss of sodium. So maybe it could be sweating or anything like that. So they're experiencing an extreme loss of sodium. The role of your body is to try to bring you back to homeostasis. So normal sodium level, let's say it's 135 to 145 millimoles per liter. So this is what your body will always try to achieve in terms of your sodium level. Now, if the patient has lost sodium, it means that they would be hyponatremic. So the kidneys is going to try to bring them back to achieve this 135 to 135, pardon me, to 145. So what would the body do? In order to bring that is the kidneys will hold on to lithium in an attempt to replace that lost sodium. Because remember earlier we said lithium closely resembles or acts like sodium in the body. So in this case, the kidney is saying to bring the body back to homeostasis because my patient is hyponatremic, I'm going to hold on to that lithium to balance the body or bring the body back to 135 to 145. As a result, the patient is now at risk for lithium toxicity. Let's say the reverse was the case. Your patient has ingest too much sodium. So something happened, you've ingested too much sodium, or patients got dehydrated where they end up with their blood become very hypertonic, or the patient is in hypernatremia. So again, the kidney will try to bring you back to homeostasis, bring you back to this 135 to 145. And in doing so, it has to decrease the blood sodium level. But remember again, the kidney is not going to get rid of sodium first. It will get rid of the other item that is acting like sodium, i.e. lithium. So you'll see increased excretion of lithium by the kidneys. And once the lithium is lost, what is your patient going to be experiencing? Your patient will then be subjected to subtherapeutic levels. So they're under what they're supposed to be receiving. Okay, so they will end up with subtherapeutic levels. So in a nutshell, when the patient goes hyponatremic or they lose too much sodium, then the body is going to hold on to lithium, so your patient is at risk for lith toxicity. Whereas if they've ingested too much sodium and they're hypernatremic, then your patient will increase their excretion of lithium by the kidneys and at risk for subtherapeutic levels. In other words, then the patient is now at risk to experience or increased risk of experiencing episodes of mania as their medication is at a subtherapeutic level. One thing to add is the lithium drug has to be monitored very closely in these patients as it has a very narrow therapeutic index. And what do we mean by that? They can easily fluctuate between toxicity and subtherapeutic levels of lithium levels in the blood, primarily because it is so close and it so closely acts like sodium and it's regulated by the kidney. So patients that are on lithium are usually monitored every 1 to 3 days when they start the treatment. But once they've been on the treatment, then at the least every 2 to 3 months after that, they need their lithium levels checked. If they're in the community, usually for patients that are really compliant, they will take it upon themselves or through the psychiatrist or family doctor to have their lith levels checked every 2 to 3 months Other patients that are probably in the community that are not coping very well usually have a caseworker that's assigned to them that would ensure, or at the best try to ensure, that these lithium levels are checked in these patients and they're complying with maintaining that level of lithium.